Okay, um, I'm Vimal Nanavati. I am the instigator and the one who started this course, and I'm kind of happy given the fact that we've had such great presenters so far. So I am going to review the major PCI trials. I focused principally on the prospective randomized trials. So with that, I will tell you there's a lot. So I'm going to try to get through these trials as quickly, but try to get to the salient points for each one. Okay. So okay, here's my disclosures. Um, we already talked about this with Dr. Ross, so I'm not going to speak about the Modern 1 trial, so iModern, so we'll skip out that. So the Target First trial was presented at AHA, was early aspirin withdrawal in low-risk patients. The key finding is safe in selected low-risk patients, and the implication is there is a potential for tailored antiplatelet strategies. This was a total of 1,942 randomized patients. They were randomized to 961 to receive P2Y12 monotherapy versus the 981 to continue dual antiplatelet therapy. This was multi-center open-label randomized trial of 40 European sites. It involved adults with acute myocardial infarction who had undergone successful complete revascularization within 7 days after the infarction. They subsequently completed 1 month of dual antiplatelet therapy with no ischemic or major bleeding, and then they were then randomly assigned to transition to P2Y12 inhibitor as monotherapy versus dual antiplatelet therapy for an additional 11 months. The primary outcome was composite of death from any cause, myocardial infarction, stent thrombosis, stroke, or major bleeding, defined as BARC 3 or 5 at 11 months. This was a testing for non-inferiority with a margin of 1.25. The main secondary outcome was BARC type 2, 3, or 5 bleeding, which is clinically relevant bleeding at 11 months. And this was tested for superiority. So the exclusionary criteria, important to know who were excluded in this. And these were people with high risk of bleeding, obviously, kidney dysfunction, active bleeding with a hemoglobin at the outset of less than 13 or less than 12 for women, cirrhosis, history of bleeding diathesis or thrombocytopenia, and most importantly, those with a high risk of ischemic events if they had undergone complex PCI and had specifically chronic total occlusion, left main disease, and had received stents that totaled more than 80 millimeters in length, or had severe calcification. These are all high risk features, and so they were actually excluded. Okay, so this is the how they were randomized. There were very few that were lost to follow-up. There were 6 lost to follow-up in the dual antiplatelet, and 6 on the in the monotherapy. So it turned out 961 were included in the intention to treat, and 981 in the dual antiplatelet arm. And these, all of these basic demographics were essentially equal except for a few items, and I've just highlighted them here. In the P2Y12, there was a slightly higher percentage of people who had peripheral vascular disease. Chronic kidney disease was a little bit higher with the DAP arm, and then lower EF of less than 40% was a little bit higher in the dual antiplatelet arm. Other than that, everything else was essentially equivalent in the demographics. And this was the Kaplan-Meier for the primary outcome on the top, and the secondary outcome with the BARC bleeding, BARC 2, 3, and 5 bleeding. You can see that they were essentially equivalent for the primary outcome, but in the bleeding, kind of not surprisingly, the monotherapy was much less versus the dual antiplatelet therapy. And this was days, 335 days from the onset of randomization. And here you can see that there was very little, there was some benefit, but the confidence intervals are large and they crossed over the equipoise line. So difficult to tell on the primary um, outcome arm, which got which was much superior, but in the secondary arm, you could see that the bleeding was significantly less in age less than 75 years old, people who were non-diabetic, people who were male, and actually, interestingly, those who had STEMIs. So this is a little bit of a, single vessel disease, single lesion, age less than 75, STEMIs and non-diabetics and males all had lesser lower bark 2, 3, and 5 bleeding versus the DAPT. So this is a target for one conclusion. Converting to P2Y12 monotherapy may be a viable option after initial DAPT in some non-complex PCI and can result in lower severe bleeding rates. On to Cincinnati. There were 5 trials in intravascular lithotripsy, IVL, and calcified coronary disease. And I'm going to go through all of them. So the first one was a shortcut trial, IVL versus cutting balloon. They compared IVL with cutting balloon angioplasty for preparation of calcified coronary lesion. This was also prospective randomized multi-center trial. And it was interesting, it was imaging-based assessment with OCT and IVUS. And specifically, they looked for more than 270-degree arc of calcium on OCT and IVUS. They had to at least have that. It wasn't one of those where you just do an angiogram and, oh, I might see a little fleck of calcium. Okay, that's calcification. They actually literally did intracoronary imaging, and verified that there was a significant amount of calcium before they were enrolled, okay? So this was very important. The patients had to have moderate to severe coronary calcification, and then they were randomized to IVL versus cutting balloon prior to DES, final DES implantation. So this was a preparatory type of which prep got better stent expansion. So in the shortcut trial, there's a little bit of a wrinkle in this where they used rotablator. So if the rotablator was used prior to cutting balloon, the final stent expansion was equivalent between the cutting balloon and IVL. But if the rotablator was not used prior to cutting balloon, the final stent expansion was inferior to that of IVL alone. So in other words, the cutting balloon was kind of dependent on the rotablator. If the rotablator is used first in calcified plaque debulking, then even IVL was not needed for optimal stent expansion because rotablator did the job. So the rotablator was a little bit of a wrinkle in this entire trial. And if you look at the primary outcomes, so we were looking at final stent expansion. So after you did either the cutting balloon or the IVL, what was the post-procedure MSA? They were literally looking at the post-procedure MSA and the procedural success and peri-procedural complications. The key result was the IVL achieved similar stent expansion to cutting balloon. That's important. High procedural success in both arms, low rates of perforation and dissection in either arm, and Dr. Suzanne Barron, who was the principal investigator, stated in the TCT discussion that took place after that the cost of IVL, they actually cost itemized this with which catheter that was used, which each wire was used, how much radio contrast, so they itemized every single thing for IVL and cutting balloon, and it turned out that the cost of IVL significantly was higher compared to cutting balloon. So it's a good thing the IVL rep is not here. IVL versus cutting balloon implications. So yes, IVL is safe and effective, and it is a safe and effective alternative to cutting balloons. The good thing about IVL, and the reason why it's so widely utilized, is that there's less operator dependence and it's more predictable for calcium modification as well as for debulking. and it's particularly attractive for concentric or deep calcium. So Victory, on comes Victory trial. Victory trial was an interesting trial where they used lithotripsy versus super high pressure balloon. I mean, super high pressure, we're talking 40 millimeters of mercury pressure. So I think the highest I've ever done with a non-compliant balloon is like 22, 23 atmospheres. They're talking 48 atmospheres. This was to determine whether IVL is non-inferior to super high pressure non-compliant balloons for calcified lesions. This was again multi-center randomized non-inferiority trial. Patients with heavily calcified resistant coronary stenosis, again with more than 270-degree arc of calcium or coronary OCT on coronary OCT imaging, or grade 3 level of calcification on angiogram. The IVL was compared to high pressure, ultra high pressure balloon angioplasty with the OPN balloon. This is a product that's seen on in European cath labs. OCT guided assessment. Then they did OCT guided assessment of the lesion prep. So subsequent to final stenting, they did an OCT guided assessment to see how much MSA, how much area was actually was gained. Okay, so the reason was to try to get the best stent expansion as possible, and that was the real outcome for the reason of Victory. That was the reason for the Victory trial, because the better debulking that you do, the better stent area that you can utilize. Okay, so balloon angioplasty with the high pressure balloon versus shockwave lithotripsy IVL were randomized 1-to-1, and the high pressure balloon was a Swiss balloon called OPN NC balloon. Total number was 282. There was OCT for each vessel, stable stent implantation, and stent expansion was similar between either group. And the result was a 30-day follow-up. There was no significant difference in outcomes such as myocardial infarction, repeat revascularization, or stent thrombosis. So the endpoints were again the same as the previous trial with the cutting balloon. Final stent expansion, acute procedural success, and safety endpoints such as dissection and perforation. And the key finding was that the IVL, which is lithotripsy, was non-inferior to OPN high pressure balloon for stent expansion. It had a comparable safety profile, and there were fewer extreme pressure inflations required in the IVL, understandably, because you didn't have to use the OPN balloon. But interestingly, the principal investigator who spoke at the TCT stated that despite the higher extreme pressures used, there was the same amount or less dissection and perforation, simply because there was a 1-to-1 diameter used. So if you use a IVL balloon that, if you use a OPN high pressure balloon, you should not increase the size. You should just keep it at the same size as the vessel or slightly less. And that resulted in better safety endpoints and lesser dissection and lesser perforation. So the conclusion is the IVL provides effective calcium modification without the extreme balloon pressure seen in the OPN, but they may reduce the risk of vessel injury in fragile or eccentric lesions, and so therefore IVL should be considered as first line in selected high risk calcified anatomy. But at the same time, the OPN balloon works just as well in most calcified lesions, so that should also be considered as an alternative where IVL cannot be used, or it's cost prohibitive. So OPN balloon was equivalent to IVL. It's non-inferior. It supports the use of OPN high balloon where there's a cost issue. Vessel sizing is more important than high pressure balloon inflation. So it's the sizing of the vessel, like I stated earlier, that reduces the dissection rates and the perforation rates. The super high balloon inflation was used with no higher complication rates if sized with vessel correctly. And this was as per Matthias Boussard, who was the principal investigator for that trial. Then comes the Bali trial. Again, this is the adjunctive IVL strategy. So should we use IVL as an adjunctive strategy versus primary strategy? So it was compared to conventional lesion preparation. There was a randomized multi-center trial again. IVL was based, either it was used as IVL-based strategy versus standard balloon-based preparation, and this was in complex calcified corneal lesion, and again, imaging-guided PCI. Endpoint stent expansion, just like the other two trials, need for bailout atherectomy and procedural complications. The key findings were there was acute lesion compliance with the IVL strategy. There was reduced need of bailout calcium modifying devices, and they had a favorable safety profile. So the implication is that IVL use can be used as a primary strategy rather than just a bailout. May simplify the procedural algorithms in complex calcified lesions, and it reinforces the imaging-guided calcium assessment, which I feel should be done before and after. When you deal with calcified lesion, you should do it before you proceed with stenting, and then debulk as necessary, and then after stenting, you should definitely do imaging. Why? Because most of the time it's underdeployed, and you have to do further balloon expansion. So again, roller coaster Epic 22, IVL versus atherectomy, similar, and I'm not going to spend too much more time on this. This was a 1-year clinical and imaging follow-up, and this showed that IVL achieved comparable stent expansion, lower procedural complexity versus atherectomy, and favorable safety profile. So again, IVL seems to be emerging as a less aggressive calcified calcium modifying option, may reduce the need of atherectomy in selected patients, but again, it's important. It may be an important adjunct in operators with limited atherectomy volume, like rotablator. The role of IVL in PCI has become concentric or deep calcium, long and diffuse calcification, and in order to really tell, as we talked about in earlier trials, imaging with IVUS or OCT should be the guide device, should guide the device selection, and IVL complements, but it doesn't place atherectomy, as you saw in that rotablator in the initial shortcut trial, and the OPN balloon and cutting balloon were found to be non-inferior to IVL. So now on to another discussion more about alteplase, and I'm not going to spend a whole lot of time on this. This was to determine whether adjunctive intracoronary delivery of low-dose alteplase reduces microvascular obstruction or major adverse cardiac events in patients undergoing primary PCI for STEMI and high thrombus burden. This was also a multi-center randomized double-blind trial undergoing primary PCI for large territory STEMI and high thrombus burden. This was randomized to receive alteplase 10 milligrams or 20 milligrams versus placebo, administered directly into the infarct-related artery using a delivery catheter after antegrade perfusion was established. N of 210. The endpoints were major adverse cardiac events, including, and also myocardial blush grade, distal embolization or failure to achieve more than 50% STEMI resolution at 30 minutes post-PCI. And the MACE was composite of cardiovascular death, myocardial reinfarction, cardiogenic shock, or new onset heart failure in 30 days. So if you, this basically was a negative trial. It did not show any improvements. In fact, the endpoints were the same. And in fact, there was a higher incidence of VT during administration of alteplase during STEMI. So the routine administration of this therapy in patients with STEMI undergoing primary PCI is not supported by data from this trial. So this was a negative trial. Now, I'm not going to spend too much time with the Noble 10-year outcomes because this was a 10-year outcome trial. It wasn't a new trial. This was just more of a follow-up, so I'm going to skip that and then talk about the percutaneous interventions during TAVR. This was brought up Like the question is when to do percutaneous intervention. If you, when you're doing a TAVR, you discover high-grade coronary lesions, should you do it a priori? Should you do it at the, or should you wait until after you do the TAVR? So that's the question came up. So up to 50% of patients undergoing TAVR had concomitant coronary artery disease, and 10 to 20% of all TAVR patients had concomitant PCI performed. And so the Notion 3 trial was to look at the hypotheses that routine revascularization of coronary artery stenosis with a fractional flow reserve of 0.8 or less, with a coronary artery diameter stenosis of at least 90% by angiography with PCI in addition to TAVI in patients with stable coronary disease and severe symptomatic aortic stenosis would improve clinical outcomes. So they're saying if you find high-grade lesions, before you do the TAVR, do the percutaneous intervention. Will that benefit or not? That's the question. So this was an international open-label randomized superiority trial involving patients with coronary artery disease and severe aortic stenosis undergoing TAVI. These were all centers in the Nordic Baltic region, 455 patients, funded by Boston Scientific and Danish Heart. So the inclusion were severe symptomatic aortic stenosis and at least one coronary artery stenosis with the criteria I described. They were randomized with PCI versus conservative treatment with all patients undergoing TAVI. The primary endpoint was MACE, defined as composite of death from any cause, myocardial infarction, or urgent revascularization. So the demographics were essentially equivalent. And these were the angiographic findings. So if you look, so the syntax score was 9 and 9. So these were timing of PCI before was 74%, 17% was concomitant with the TAVI, and after the TAVI was only 9. So that's important to kind of remember. And the median days after the TAVI procedure was 34, and the balloon expandable heart valve was 90 days. So now looking at that, you can see that in the blue was the conservative treatment, PCI was the kind of orangey color. So the PCI was for freedom from primary endpoint. There was a slightly better with PCI, no change from death of any cause. Myocardial infarction, slightly better with PCI, but again, not statistically significant. And then again here, PCI was a little bit better. Again, not statistically significant. And here are the most of the criteria. If you look at the demographics, they were improved in the PCI. So it was better in the PCI arm. The only ones it wasn't was people with less than 40% EF, and those with basically that was it. And then also less than 90% stenosis of the coronary artery that they were looking at. But pretty much everybody else improved with using PCI versus doing conservative. So percutaneous intervention in TAVR, the PCI performed before or at the time of TAVR shows improved MACE versus conservative therapy. All patient subsets benefits from PCI except patients with LVF less than 40, but there was too wide of a confidence interval even in that one. And 74% of the PCIs performed pre-TAVR, as I stated, 17% at the time of the TAVR, and only 9% performed after the TAVR. So, in other words, if you're gonna do a TAVR, you should definitely consider doing PCI prior to or at the time of the TAVR, and that would be a better approach rather than waiting. And doing the PCI definitely improves MACE rates. So I'm not going to spend a lot of time in this aquatic trial because it was kind of a negative trial, and it makes sense because if you looked at it, it was patients with chronic coronary syndrome who had undergone a previous stent implantation more than 6 months before enrollment and were at high atherothrombotic risk and currently receiving long-term oral anticoagulation. Should you give them aspirin plus oral anticoagulation? And the answer was a resounding no. And the study was actually stopped early because it had higher mortality rates with the oral anticoagulation and aspirin combination, and therefore this trial was negative. And these are just the Kaplan-Meier curves showing you that. So I'm not going to spend a whole lot of time. It was kind of obvious. I'm going to overview the Impella trials. There was several of them. There was only one prospective randomized trial. They looked at Impella CP and Impella ECP. They randomized in cardiogenic shock, prospective high-risk PCI trials, and shift towards early unloading and standardized protocols. The Danger Shock was the only prospective randomized multi-center trial that was reported in the ACC originally and then the TCT as well. It was the first definitive randomized controlled study showing mortality benefit from Impella. The population was AMI-related cardiogenic shock patients, and they were SCI stage C and E. And they had to have, they're protocolized for early presentation. So that was the population that was selected and included. The primary endpoint was all-cause mortality at 180 days. And you can see the standard Impella plus standard care alone, which is vasopressors plus intra-aortic balloon pump, plus or minus. Early LV loading was emphasized, and strict was protocolized for shock management. So the key findings here is there's significant reduction in mortality in the Impella arm, improved hemodynamic stabilization with acceptable bleeding and vascular complication rates, and the benefits were the strongest with the early placement of the Impella, lower lactate levels, and fewer escalation steps prior to Impella. So the sooner you put it in, the better off the patient gets. The Impella CP improved survival in selected AMI shock patients when used early and within a structured shock protocol, and this was cited prominently in the ACC and TCT. Impella ECP pivotal trial was a prospective single-arm IDE study. It was not randomized, but pivotal and prospective, often discussed. So device was the ECP Impella, which is expandable, had a smaller access profile, which is key, and designed specifically for PCI support. The primary endpoint here was 30-day MACE and device-related safety outcomes. And if you look at that, the MACE rate was significantly below the pre-specified performance goal. There was high procedural success and favorable access safety. The relevance is that it was presented at TCT. It was positioned as the next generation PCI support device, which is the ECT, and it's complementary to randomized shock data, which was presented at the Danger trial. So the Impella ECP actually broadens the mechanical support options for elective high-risk PCI with improved deliverability because of its smaller profile. So PROTECT 4, prospective randomized, again, high-risk PCI population. Impella protected PCI versus standard PCI without mechanical support. Again, endpoints were peri-procedural MI, hemodynamic collapse, long-term clinical outcomes. And this is ongoing. This isn't complete yet. So you will see the results of it later, maybe in 2026, later this year. The PROTECT 4 is designed to address the criticism of prior non-randomized PCI data, and it's hopefully it will have the definitive randomized PCI support trial. We'll see, and we'll see if it changes the guidelines. So this is finally the National Shock Initiative door to unloading strategy. This is a protocol-driven, not randomized prospective trial, early Impella placement before PCI, door to unloading concept. Why does it matter? Because it helps explain why the earlier trials failed. It reinforced timing over device selection, and it used to contextualize danger, shock. Why was that successful? So this is just a summary slide showing you so far the only randomized trial is the Danger AMI. It shows reduced mortality with early Impella use. These others this is not prospective. This is Protect 4. It is, but it's ongoing, so we'll know the results later in 2026, hopefully at TCT. And this is Shock Initiative is protocolized. So again, the results are still pending. This is for my Chicago cronies. Solution de novo trial. Now this is where we are talking about what you call, things that will disrupt the standard of care. So these are kind of disruptive trials. And so this is a de novo trial of sirolimus drug-eluting balloon versus drug-eluting stent. And we know that permanent metallic stents have long-term limitations, including in-stent restenosis and stent thrombosis, and also not to mention the caging of the coronary arteries if you do a long stented area. So the drug-eluting balloons deliver anti-proliferative therapy without leaving any metal behind, which is very attractive. So this was presented in TCT late-breaking trials. And this was a prospective randomized multicenter non-inferiority trial. I know that Dr. Roche loves those. Solution SLB drug-eluting balloon plus a bailout stent versus contemporary DES. 3,300 patients, so not an insignificant number. Patients were randomized 1-to-1 to either drug-eluting balloon first strategy with provisional stenting or routine DES implantation. The lesions treated were de novo native coronary lesions with reference vessel diameter greater than between 2 and 5 millimeter range, excluding left main, CTOs, and venous grafts. The primary endpoint was target vessel failure at 1 year and composite of cardiac death, target vessel MI, and clinically driven target vessel revascularization. So the demographics are equal in each arm. The ACS was 45% in each arm, 55% in each arm. Coronary treatment distribution in each arm was equal. Reference vessel diameter was 2.8 millimeters. Lesion length 18 to 20 millimeters. Moderate to severe calcification was 30% in each arm. Bifurcation lesions 12% in each arm. So they were not exactly simple type A lesions. Okay, bifurcation lesions were 12%. Imaging guidance was used 35 to 40% in both arms, which is somewhat surprising to me, given the fact that they were somewhat complex lesions. And then bailout stent rates were 20 to 25% in the balloon arm. Okay, so that's important. So if you look at the inclusion criteria, I just stated that already. And exclusion criteria were people who had a STEMI or a non-STEMI. There was in-stent restenosis. They had previous PCI or on the target lesion, or they had left main, saphenous vein, or arterial conduit, or chronic total occlusion. We did not include those people. So if you look at the results, the target vessel failure, which was the primary endpoint, was the non-inferiority was met with the DEB balloon. Cardiac death rates were not significant. Target vessel MI, not significant. Clinically different TLR, not significant. So that begs the question, should we not be considering drug-eluting balloon as a primary PCI strategy versus then just going to the stents? So again, the safety outcomes are also similar. If you look at definite and probable stent thrombosis 0.5 to 0.6, really all of these were essentially the same in the DEB versus the DES. So it begs the question, should we then make DEB the PCI strategy of default strategy? This is the largest randomized DEB trial in de novo disease. 80% of the drug-eluting balloon-treated patients did not require a stent. Yes, 20% did. Okay, demonstrates proof of concept. So this is what the key is. It shows that this is a viable option, and it's although there's no superiority, there was some strategy equivalence, and the long-term durability still awaits 5-year results. So we don't know what the 5-year results are of this. We don't even know what the 2-year results are. But there was no safety penalty for DEB first and stent optional strategy. So we're kind of changing our thought process. This is the first trial that is putting that kernel in our heads as interventional cardiologists, that maybe we should be considering DEB as a first option, okay, for obvious reasons. Then comes this is even more enticing, the Infinity Sweetheart study. This was a Dynamax Bioadapter stent. It's not available right now in the United States, it's only in Europe. It functions initially like a DES, drug-eluting stent, but unlocks as the polymer reabsorbs in 6 months, allowing vessels to return to its natural motion. So at 6 to 24 months, the target vessel failure was reduced by more than 50% versus our current conventional DES stents, which is amazing. This is an adaptive scaffolding that can redefine our current approach to stent implantation. And it follows the less is more concept, which I'm trying to convey to you. It may redefine our durability and late event profiles by offering freedom from permanent metallic cage from the stents, while still maintaining early anti-proliferative benefit. So it's kind of doing the best of both worlds. So I'm not going to spend, I didn't have a bunch of slides on it, but I do think that is going to be there will be forthcoming trials to show the benefit of this Dynamax stent. It's basically a stent where the drug-eluting part of it gets basically elutes away. So the polymer elutes away after 3 months. And so there is a final skeleton of stent, but is much less than the current conventional stent scaffold, like on the order of 1/3 the amount of metal. So it allows, I'm dwelling a little bit more on this because I find it fascinating. It allows for the vessel to continue with its normal motion, because if you look at multiple stents placed in a coronary vessel, what happens is the coronary motion changes. It reduces coronary motion, and so the normal vasomotor function of the coronary itself is reduced. And so by doing this, you preserve that normal coronary motion, and that thereby may reduce the incidence of stent thrombosis and stent restenosis, which was actually found to be the case in that Sweetheart trial. NICO Assist was also presented. It was comparable to intra-aortic balloon pump in high-risk PCI. But I'm very intrigued by this new stent that's going to be coming out. Then finally, the Proctor trial. This is kind of something that we've always grappled with. What do we do with saphenous vein graft disease? In the current guidelines, basically we perform native vessel PCI if possible. That's our strategy. And we randomized in this Proctor trial, we randomized a trial looking at native vessel PCI versus SVG PCI. And it looked at vessels that were more than 50% diameter stenosis in the vein graft. There was only 220 patients. There was 108 went to native PCI and 112 were randomized to PCI to the saphenous vein graft. There was a crossover 12 from the PCI, the saphenous vein graft group, and cross over to the native PCI, native PCI to 3. The endpoints were at 1 year, all-cause mortality, target territory, non-fatal MI, and clinically driven TLR. And basically the results of the Proctor trial showed that there was a significant improvement in endpoints at 1 year using PCI to the SVG versus PCI to the native vessel. So what was our previous fallback strategy of doing PCI to the native vessel is now turned on its head, because now it was shown that PCI to the SVG had lesser endpoints, lesser mortality, lesser target territory, non-fatal MI at 1 year. Okay, so then we have to rethink our strategy on this. Does this apply to all saphenous vein grafts? No, because these were basically single lesion SVG lesions. They weren't like multiple lesions or generally diffuse vein graft disease, that kind of thing. It was just single focal lesions. But still, it was a provocative trial in terms of thought process, what we usually do. The FAME-3 sub-study, PCI versus bypass, I'm just gonna run through these real quick. The key finding with this was that PCI was more cost effective than bypass in certain scenarios. There may be an economic advantage of doing PCI. And then the dose trial, they said, okay, whether do you have higher radiation when you do radial? That was the thought process. It turns out that there's a similar exposure between radial and femoral access, and the implication is that you can use either side. Radiation dose is essentially the same. A Celebrate trial, there was a new injectable drug in heart attacks. The key finding was improved outcomes in suspected heart attacks, and there's maybe a potential new adjunct. Neo Mindset, again, aspirin withdrawal versus dual antitherapy, dual antiplatelet therapy, and found that early aspirin withdrawal was not non-inferior in reducing ischemic events. And so the implication is that dual antiplatelet therapy remains a standard for now. So that is my whirlwind, and I apologize for the length of the talk. Thank you very much. Any questions?
What's your current practice for calcific lesions in terms of how to pre-modify the lesion?
I would do OCT or IVUS and see how much calcification there is, because angiograms are not exact, and I'd like to know exactly how much calcium we're dealing with. And if we're dealing with high amounts of calcium, then I would go with a high pressure balloon. If the high pressure balloon fails to do what we need to do, then I'll go straight to IVL. So.
I might not know this, but just asking, on the recent study that you showed, the provocative one, right? It was the PCI on the single vessel SVG. So what in your mind, why was it showing lower mortality compared to native?
I think because native vessels tend to deteriorate faster, and I'm sure that Dr. Rosh would agree. What happens with native vessels when you bypass them, that lesion, which was bad in the first place, gets worse, and then it also develops calcification, and so you have to do a lot more, and so it's a much more complex lesion treatment, often requiring IVL or high pressure balloon inflations. So just dealing with a single discrete vein graft may be a safer option, especially when we have adjunct balloons, safety balloons, filter balloons, and those kind of things. Filter wires are helpful. I've done 2 of them, and really amazing results. As long as you have a filter wire in place, it's really very, very easy and impressive results. So.
I think also in that trial, the natives, there were a lot of CTOs.
Yes,
So it's comparing like just the SVGs were not CTOs; they were just that focal
Exactly.
lesion. So you're comparing extending that versus opening up a CTO.
CTO is very high complex. That's the problem. They become much more. They accelerate because the bypass grafts has replaced the flow. So then there's less flow in the native. So then it accelerates the process in the native vessels. So anything.
One other question was on the Impala study that you showed, and there was one with standard of care and then Impala by itself, right? How early did Impala get put in these patients?
I don't know the exact timing, but the danger AMI, it was advised to put in almost immediately before. So unloading, the whole concept was unloading before the intervention. So I don't remember now when exactly it was put in, but it was supposed to be put in before the PCI. So like you're coming in with a STEMI, and it's so you put the Impella in first, and then you do the percutaneous intervention. So the whole paradigm has shifted to the time to unload. Time to unload means that the sooner you unload the ventricle, reduce the LVDP, and then perform the percutaneous intervention. So it's changing slowly, especially with the lower profile Impella device.
And I know you showed that adding that Impella reduced mortality, so if the Impella would be put earlier, the mortality should go down.
Right. Remember, with they actually use the criteria of lower lactate levels to try to get to them earlier before it gets worse. Any other questions? Thank you so much.
Thank you.
Yeah.